All right, good afternoon. We're going to get underway here. I'm Jeff Anderson from the Peace Studies Department, and on behalf of the Peace Studies Department, I want to invite you to welcome you to our third panel, or our third event of the day, which is featuring Dr. Dan Hoody with Doctors on the Front Line from his experiences at Hennepin County Medical Center. And we have a couple of students who will be serving as rapporteurs, discussants, but following his talk, that just means that they'll give a little initial reaction, but then all of you will go to a nice, healthy Q&A, so you can ask questions directly to the doctor, okay? Nothing about rashes or, ears that are ringing, but otherwise anything on health disparities is definitely encouraged, okay? The Peace Studies Department puts on this conference. It wouldn't be possible without Sheila Hellerman here, who did a wonderful job with all these details. We're also supported by the CSB SJU President's Offices, by the Pre-Med Club, the Black Student Association, the Global Health Affairs Club, the Peace Studies Club, and behind all this, as I'll mention in a more detailed way tonight at Dr. Tweedy's address, the Peace Studies Conference gets funding from Robert and Lorraine Breitenbucher, who have since passed, but they thought of us, okay? And so they've funded all 29 of these conferences over the years. And he was a physician in the Twin Cities area, and Lorraine was actually a nurse who taught my dad, who is a medical doctor, lab techniques. Small world there. They were members at St. Joan of Arc Church, very concerned with kind of proper relations and things like health disparities and all kinds of different disparities. So if you find yourself with an interest, a growing, hopefully, interest in these types of issues, try and surround yourself with other people who share those interests and concerns, and you'll do well. So right now I'm going to turn it over to Matthew Bergstaller to introduce our speaker. Thank you very much.
So for those of you just joining us for this afternoon's session titled Doctors on the Front Lines, welcome. For those of you who are staying for another exciting session, welcome. My name is Matthew Bergstaller. I'm a junior integrative health science major here at CSBSJU with a passion for peace studies, and particularly as it applies to healthcare. Today I have the honor of introducing our next speaker, Dr. Dan Hoody. Dr. Hoody is a hospitalist at Hennepin County Medical Center, HCMC. Recently, Dr. Hoody arranged for our McCarthy Center public health study tour to visit with his colleague and SJU graduate, Dr. Mike Lawson. After about an hour with Dr. Lawson, our group concluded that the hospital truly is kind of the front lines of service in the battle against racial health disparities. Dr. Hoody attained a bachelor's degree in chemical engineering from Notre Dame University. He then graduated from the University of Minnesota Medical School. He completed his residency in internal medicine at the University of Colorado Health Sciences Center. But beyond his hospitalist duties, Dr. Hoody is also the Chief Medical Quality Control Officer at HCMC, thus heading up the efforts to improve care. Again, the front lines. If these credentials were not enough to excite you, Dr. Hoody also has another lens to observe and fight health inequity, as he recently completed his MSc in Health Economics, Policy and Management through the London School of Economics and Political Science. Please join me in extending a warm welcome to Dr. Dan Hoody.
Thank you, Matthew. Sound check? Good. Okay, 1 minute here. Okay, so like Matthew said, I'm a hospitalist at HCMC, and I am honored to speak to you today about this very important topic. And so I want to start out by one of my favorite quotes from one of my engineering professors in undergrad, which was always, when you hear something or you listen to a speaker, always think about what was said and who said it, and the second part being the most important. I didn't know Matthew was going to give me such a generous introduction, but I wanted to tell you a little bit about myself so you know where I'm coming from, what my background is before we move forward. And so I'll highlight a couple of points that Matthew said that I think are pertinent to today. I was an engineering undergrad, which gave me a little different lens to go through medical school and medical training than the traditional pathway. The second part is the Master's in Health Economics over in London, which gave me I think, long overdue introspect on the U.S. healthcare system and how to better approach the health inequities that we see. And then the third part is the Chief Medical Quality Officer it's an interesting role in that I still work with patients on the front lines, but I'm also responsible to our governance, which is the Hennepin County Board, which runs our hospital and makes sure that our mission effectiveness is moving towards the ultimate goal, which is to provide healthcare to this very important safety net population. So aside from the CV portion of things, I think it's important also to note the things that I think kind of frame my background for health inequity and social justice. A couple of things I think are worth talking about. One, that I grew up in Bemidji, which is anybody here from Bemidji? No? Nobody? Dang it. So Bemidji is about 3 hours north of here. I'm sure most of you know where it is. It is in Beltrami County, which is the second poorest county in the state of Minnesota. So as part of that, growing up, it was very apparent to see these differential exposures to multiple social determinants of health, which at the time, that's not how I would have labeled them. But as I went through my training, it was very interesting to look back on all those experiences I had growing up and then looking forward to the patients that I'm seeing that may have come from that same background. The second part that I think has influenced me is in undergraduate and medical school. I tutored in elementary schools of lower socioeconomic status areas in South Bend and then in Denver. And that was really eye-opening for me as well to see how different my upbringing was compared to the people that I was tutoring. The third thing is that I spent a couple summers in Central America through a it's actually a Catholic mission that a lot of Minnesotans go to, and part of their goal is to fight for social justice issues in Guatemala, and that really framed my lens for our patients that are coming that are not born from the U.S. are born in the U.S. And so that also has influenced significantly how I approach the patients that are coming in undocumented. The fourth thing is that I'm a proud member of Mile in My Shoes. Has anyone ever heard of Mile in My Shoes? Not many NPR listeners here. So Mile in My Shoes is it's a running club that teams up people in downtown Minneapolis with residents in the homeless shelters and the transitional housing. And so I've done that for about 2.5 years now. And that is a third unique experience that I think has really allowed me to better understand, for lack of a better way to describe it, a day in the life of someone that's homeless. And then the last part, but certainly not the least, is working at Hennepin County Medical Center, which I love. But from the workforce to the patients, to the mission that we serve outside of the patients, we see, to Matthew's point, we see every day the front lines of racial inequities in healthcare. So the first thing I want to start out with is a brief story from the Institute of Healthcare Improvement. They have a white paper on how to improve health inequities in the United States. And they start with this story, and it goes like this. Tommy Cannon died at the age of 62. A black American, he lived his entire life on Highway 29 in Perry County near Marion, Alabama, in a region known as the Black Belt. He was deeply religious, a hard worker, honest, and generous. In his late 50s, Tommy was diagnosed with type 2 diabetes. Like many other older black Americans, then and now, he had no source of regular preventative health care. One day in 1973, when Tommy became very ill, he waited hours in a segregated doctor's office waiting room trying to receive care. When he was finally seen, the physician told him to go to a hospital 50 miles away because he was so sick. Tommy Cannon died the next day at age 62 from sepsis due to a ruptured appendix at a hospital in Selma, Alabama, without ever being seen by a physician. Fast forward to 2013, the life expectancy at birth for men in Perry County, Alabama was 67.4 years, compared to 76.3 years, the national average for males in the U.S. for the same year. And so what's up here now is a graph which shows life expectancy of blacks and whites in the United States. And you can see from 1950 to 2010, life expectancy has increased for both populations, but there still exists a significant disparity. So since Tommy's time until now, while things have improved, there's still a significant gap there. And feel free to stop me if you have any questions at any time here. So before we move on, I just want to frame any discussion with trying to define best the different words that you might, or in terms you might hear in this topic. The first is population health, and that is simply the health outcomes of a group of individuals, including the distribution of such outcomes within the group. And so, for instance, if we talked about the diabetes care in the state of Minnesota as a whole, that would be population health. Social determinants of health. The circumstances in which people are born, grow up, live, work, and age, and the systems put in place to deal with illness. These circumstances are in turn shaped by a wider set of forces, economic, social policies, and politics. And so this is important as we move on in the discussion to note that there's social determinants of health that exist outside of the direct clinical care. Health disparity. So health disparity is defined as the difference in health outcomes between groups within a population. Health inequity, as defined by the WHO, is healthcare inequalities which are unnecessary and avoidable, but in addition are also considered unfair and unjust. So you can have health disparities without health inequities, but a health inequity is a subset of health disparities that are considered unfair and unjust. And then the last part I think that's worth noting is equality versus equity, because this was really confusing to me, especially when I had no economics training in undergraduate or medical school, so when I went to get my master's, I fumbled through the first week of Econ 101 trying to sort this out, and then I saw this picture and it became very clear to me. And so equality is, for instance, giving the same healthcare package to every single patient at the same cost. Equity is giving a healthcare package so that the end result is that everyone has a healthcare package in which they end up not having to pay a share more than they would based upon their income. So healthcare disparities. So racial or ethnic differences in the quality of healthcare that are not due to access-related factors or clinical needs, preferences, and appropriateness of intervention. So health disparities are related to health outcomes. Health care disparity is related to health care and the quality of health care and that's separate from access-related factors. So why do we talk about race with healthcare inequities? David R. Williams, who's published in Health Affairs on healthcare inequalities and inequities, defines race, states race is a marker for differential exposure to multiple disease-producing social factors. And it sounds like the people that were in the last lecture already heard some of this information, but it's important to note that we use race as a method to determine if there are health inequities, and that when we look at those, that there are some trends that are quite alarming. And three of the important ones that are often talked about in the literature are, for black-white disparities, are homicide, heart disease, and cancer. And the goal of this graph is to not, or this chart is to not have you understand the whole thing, but to note that what's highlighted in the red boxes are the ratios of death rates between white and black for homicide, heart disease, and cancer. And those have persisted over the last 50 to 60 years, despite our knowledge that these gaps existed. So despite what we would consider, despite some sort of interventions that were attempted, these gaps have not closed. And one big part of that, or three big parts of that, are socioeconomic status, which drives a significant portion of the disparities. Residential segregation, which also has its own contribution of significant magnitude. And then finally, medical care. And that's part of what we'll talk about today. And so on the front lines, we bring the carrots. And so the University of Minnesota had a social determinants of health conference this past spring. And the director of global health at Harvard gave a very interesting talk. And she's a medical provider. And her opening sentence and her closing sentence was this. And she didn't really explain what it meant at the beginning, but at the end, she tied her entire talk together by saying, we bring the carrots to the soup of health, the health and well-being, and we being medical providers. And so her point was that the soup of health is, there's so many more ingredients despite direct clinical care. And so I think that's one of the things that's worth focusing on. And so if we look at contributors to premature death, as in anything that causes somebody not to live to the life expectancy that they would be determined by where they were born and living, healthcare only contributes 10% to that. Behaviors is roughly a third, genetic factors roughly a third, and then socioeconomic status and environmental factors roughly a third. So the next thing to think about, hope is not the same as a plan. And so if we've known about these healthcare disparities since the 50s, and we have well-intentioned people going into medical care and medical school and other fields that deal with healthcare, we haven't provided a plan that has worked to the extent that that disparities have disappeared. And so it's interesting to note, back to our previous slide, that if direct clinical care is only roughly 10% of the effect on premature death, what else factors into it? And so this is a chart which is worth noting in that it takes, on the far left, healthcare policy, moving to the right through healthcare organizations and financial incentives, then into clinical practice and individual patient relationship. And then that individual patient interacts with a whole bunch of other factors that are that other 90% that factor into the patient's health. And so this is where I first lived. When I got out of medical school and I went into residency, I was in that little box, clinical practice and individual patient. I did medical school rotations at Hennepin County, and so I was initially exposed to a population that I thought I knew beforehand, but I really didn't know until that, members of the safety net population are pushed to the brink. They're really sick. They're forced to make decisions that most of us will never have to make. And it was really interesting, it was really frustrating, and it was really inspirational all at the same time. And I don't think anyone goes into medicine without wanting to help people. And so, for instance, if I'm taking care of a patient in the hospital or I see a patient in clinic that fits into one of these categories where there's a health inequity, I want to help that. I want to change that. But one of the big struggles that we have as providers in this day and age is that there's a whole host of things that we are asked to do or required to do in order to fulfill the requirements of our job to that patient and to our organization. And so if we spend 20 minutes trying to overcome a literacy gap related to a patient that has diabetes in the hospital, then that 20 minutes offsets something else that we would have to do for another patient down the way. And so you end up having a list of 50 things you need to do in a day, and if you spend a whole bunch of time on 5 of those in your individual effort to try to overcome whatever the healthcare disparity is or the gap is in a certain patient that takes more time than another patient, so you spend a lot of time on 5 of the 50 tasks, you're going to drop other things off. And then stuff gets left out. And so that's not a very efficient way to provide direct clinical care, because you put out one fire and another fire comes up. It's kind of like whack-a-mole. So historically, that's the healthcare system that we've had in dealing with inequity, is that you try to fix it one-on-one. It's an oversimplification to it to an extent, but we haven't had policy that has driven change as effectively as we've wanted, and it leaves frontline clinicians who have empathy towards the patient trying to fix it on their own. And it's not a very efficient way to do it. So hope is not the same as a plan. So the second quote I think is worth thinking about is, to improve health equity, organizations first need to understand where disparities exist. And so a story that I'll tell here is that the Hennepin County Board of Commissioners oversees Hennepin County Medical Center. And there's a subcommittee of the board that's called the Quality Subcommittee. And in 2012, one of my colleagues was asked to be the chair of this Quality Subcommittee. And he sat through 5 straight board meetings in 2012, which are 4 hours long. And so these board meetings go over the entire governance of Hennepin County Medical Center. And in the first 5 meetings he was at, there wasn't a single minute devoted to any quality measure whatsoever. And so, and that's just a quality measure, not even a disparities in quality measure. So we weren't even talking about healthcare quality at the level of governance, which is the level that allocates resources. And so this quote I think is interesting, because we didn't even know where our disparities existed. And so that moves us out of the clinical practice individual patient box and over into this healthcare organization policy and financial incentives box. And part of the reason I bring this up is that I went through all of my training not really understanding that probably the largest effect you can have on the overall health and well-being of a population, going back to our initial definition of population, the largest effect you can have is working on this upstream side. Because downstream, you're just bringing the carrots. The rest of the soup is made up here and on the right side. So one of the things that we've done at Hennepin County, because health policy has started to change now, is that we now have data analysts, so people who went through undergrad and then have masters or PhDs in epidemiology or statistics. They're crunching the numbers for us and then manipulating that into a fashion where we're able to identify gaps in our patient population in order to best target our allocation of resources. So that's an important point that occurs outside of that last box. So you have to understand where the disparities exist. In order to do that, you have to resource the people that are going to give you that information. So the second quote, or the next quote, is meeting pay-for-performance targets for common chronic conditions such as diabetes will not be achievable without reducing disparities. So what does that mean? So pay-for-performance is a policy where the U.S. government has tried to drive quality in healthcare and to try to drive allocation of resources into quality where it wasn't before. So in 2012, our board didn't talk about quality because there wasn't necessarily a financial incentive associated with it. Well, policies have changed to more what we call value-based or quality-based reimbursement. And so now there's a renewed or a new incentive for healthcare organizations to dedicate the resources to focus on quality. So that's what pay for performance is. The state sets a target for Hennepin County to hit. If we hit that, we get reimbursed at a higher level. And this quote is from the Institute of Healthcare Improvement again. So meeting pay for performance will not be achievable without reducing disparities. So at Hennepin County, our optimal diabetes goal is 35%. And what that means is that 35% of our patient population gets a 5-item bundle of diabetes care that's considered best practice. And if we subgroup that out into race, we note that 42% of our white population gets the optimal care, 28% of our black population, and a lower percent of our Native American population. And so when we're talking about trying to, so how do we best improve quality and reduce inequity, that information helps target our interventions. So the graphic here is nothing that's worth memorizing other than to say there now exists a framework for healthcare organizations to reallocate resources and prioritize based upon government incentive to achieve health equity. But that's far from the front lines. So if we take that back to the front lines, there's a misspelling up there on Taylor, but so if you are able to effectively reallocate resources towards reducing healthcare inequity through government policy, then all of a sudden now you have an incentive to provide more high-value interventions at the bedside. And so this quote again is from the IHI, our Institute for Healthcare Improvement. It says, tailor quality improvement efforts to meet the needs of marginalized populations. And so what does that mean? So an example of that is the fact that at Hennepin County, all of our educational brochures up until last year were written at a 12th grade level of English. We had resources to 6th and 3rd grade, but we weren't using them. And so if you look at the coexisting socioeconomic factors that often go with the disparities we've already talked about, one of the big factors is low health literacy. And so tailoring a quality improvement effort to try to improve that diabetes care might incorporate reducing or changing the informational packets and brochures that you're giving to patients to something that they can actually understand and gain some meaning from. And so where can the front line really make it happen? So if we go back here, so we say that that policy was able to allocate resources so that institutions such as Hennepin County can dedicate money, time, IT, economists, so on and so forth, to try to figure out the best intervention back to the front line. So does this just mean that the frontline practitioner, such as myself, I'm just basically taking exactly what my healthcare organization is telling me to do and doing it? If that was the case, the job wouldn't be that fun. That's practicing medicine, but it's like, it doesn't seem like it's that intellectually stimulating. And yet, this is where probably the biggest gap exists. Because we can have policymakers, our data people, our economists, so on and so forth, tell us that, okay, this population needs this intervention at the bedside. But where the art of medicine lies is in getting the patient to understand the value of that intervention and getting them to do that. And one of the tools that I think is most important in this is something that historically isn't talked about in any health inequity lecture that I've been to before. But has anyone ever heard of TAPE in quality improvement efforts? TAPE is Target Actual Please Explain. And so one of the things that we do at Hennepin County, for instance, with diabetes care is, so each primary care doctor has a patient panel, and they get a printout of the patients in their patient panel that have diabetes, and then it's columned by each of the 5 indicators that is deemed to be optimal diabetes care. And if they're not hitting those, there's a little yellow box, and so at the right-hand side of their sheet is a very easily identifiable list of who needs improvements in their diabetes care. And so what we ask the clinicians to do is look through their list, find out who has a gap, who's not at the target. So there's a target which is 5 of 5, actual is 4 of 5, and then just why do they think they're not at that target? And then we say mind the gap. And so if we really focus on what's that gap on this individual metric on an individual patient, if we're able to explain that, we can then put this into a cycle of what we call continuous improvement, which is plan, do, study, act. So we gather all these explanations of why each individual patient isn't at their diabetes target. Then we can look at that, identify trends, plan an intervention, do it, study it again, look back at the target and the actual, and then see if that gap closed. There's nothing that's really sexy about this. And yet this is the only intervention that's been shown to be effective on local levels for actually reducing gaps. And one of the big transitions in healthcare, inequalities and everything else in healthcare, inequity in other financial areas, in other sectors of healthcare, is utilizing these frontline tests of change, because people that are making the policy aren't on the front lines. So they can identify that there's a gap existing, but they're not sure, or they don't have the information to understand why that gap is existing and what the plan is for the next intervention to try to improve that. And so I think it's really important to note that this is one of the things that's changing in medicine significantly for frontline providers, is that it's becoming more of a fluid environment from the front lines through the healthcare organization, up through the policymakers, back down through financial and the healthcare organization, and then back down to the front lines again. This Plan, Do, Study, Act. So the last thing that I think is worth talking about, because it's easy to say we should just allocate more resources to health inequity, but that isn't always feasible. And what this chart shows is this is what's often used in health economics for symbolizing the breadth, depth, and scope of healthcare. And so the population is on the horizontal axis, and then on the end of the wall axis is which services are covered, and then on the vertical axis is how much you're going to cover for those. And so we don't have the resources throughout the world to cover everything for everybody all the time. And yet we want to try to improve the baseline healthcare for everyone. So this is one of the simplest interpretations of our kind of the fundamental issue with our healthcare system, and yet it's one of the most complex, both from a frontline standpoint and from an ethical standpoint, to try to fix. So along those lines, because if we can't provide the breadth, depth, and scope to everyone, I think there's a couple things worth considering. The first quote I think that is really profound in my education was Romeo Dallaire. He was does anyone know who Romeo Dallaire was or is? Jeff does. So he was the UN commander in Rwanda during the genocide in 1994. And he spoke at a global health conference in Montreal in 2011 that I was at, and he talked about his experience there and his frustration with the world's recognizance of what was going on. And this was one of the most profound quotes that I heard him say. Are all humans human, or are some humans more human than others? Because it's easy to think that the U.S. at least is saying that some humans are more human than others when we look at the healthcare inequity. The last quote I think is really important to note is students are the engine of change. This is from the Roger Glass, who was the head of NIH and Fogarty. I don't know if he still is, but I bring this up for two reasons. One, because you guys are students, and two, because one of the things we're doing at Hennepin County for trying to do these rapid cycle quality improvement projects, for instance, on healthcare disparities, is we really utilize the medical students and the residents. Because they're actually the easiest people to change. And there's an inertia of sorts, or a lack with our physicians that have been trained, and the further out they are from training, the more resistance there is to change. And so I think this is really important to note that as you go off into whatever field you're going to go into, to know that don't necessarily wait for the people above you to drive change, because you guys are the ones that are probably going to be able to do it most effectively. So with that, I'll open up to questions or the panel.
Or you guys, maybe you can all sit down. That'd
Yeah.
be all right. You can take it in the center, Dan, and our 2 repertories somewhere there. So I chose these couple students, someone who'd applied to professional schools, to medical school, I'll let them tell me, and to physician's assistantship school, to PA. Okay? So if you could introduce yourselves and then just kind of reflect on the talk, and then we'll open it up for questions.
It's on, right? Yeah. Okay. Well, I'm Amy. I applied to PA schools this past summer, and I just thought it was a very interesting talk on how we as students can change healthcare in the future.
Yeah, and I'm Luke, and I applied to medical school this past summer. And for those of you out there who are, I guess, how old is everyone in here? Are you mostly sophomores, freshmen? Okay, so for those of you who are starting to get used to the field and some of the experiences you're having, this is the stuff that's becoming really important in healthcare, and you're gonna find that out. And so it's great that you're here learning about this stuff, because it's becoming one of the more important things in healthcare fields.
Yeah. So many questions.
And then I guess I
We
can
can
get
lead
the
it
ball
off.
rolling
Yeah.
here. Yeah. So one question I have is, when you were talking about at the beginning, you talked about how you can't just say, I'm going to address this disparity here, because then that backs up and time gets wasted. So when you gave the example of the diabetes charts, could you sort of explain how that would be different if those policies weren't in place, where you might waste time in addressing that particular issue if a policy like the chart that you had wasn't in place, just to sort of put it in perspective?
So if it was functioning well, how it would look, or?
So the example you described was it functioning well, correct?
Right.
So what would be an example of where it isn't, like where you would waste time if you didn't have something like that?
So one of the big things that we talk about at Hennepin is working to the level of your education. And one of our mantras is respect for all workers. And so we want people to feel like their time is valued and that it's being used efficiently. And so one example I would give is colon cancer screening, for instance. So that's another Minnesota community measure, which means it's reported to the state, and at some point it'll affect our reimbursement, because colon cancer screening has really good evidence behind it for the populations that are recommended, so it's kind of a surrogate for the percentage of patients that belong to your healthcare system that are appropriately screened for colon cancer is a surrogate for how well the operations of your healthcare system works. It's something where there's no debate about it, but so can you implement this recommendation where there's really very little debate? And historically, it was physicians looking through the chart. So if I'm in clinic, in addition to the other things, the ankle pain that my patient's complaining about, I'm tasked with, I would look through the chart to see, okay, are they greater than 50 but less than 75? And then I would have to click, so I do the mental math if their age wasn't on the sheet that's provided, and then I look back to see, have they had their colon cancer screening done yet? And so that on its own could take 45 to 60 seconds. But that's something where, so do I need to be able to figure that out on my own? No. So encouraging the patient or going through the risks and benefits of the procedure with the patient, I should certainly be doing. But can somebody else do the work up to that point to say, yes, yay or nay, this patient needs a discussion on colon cancer screening? So one of the interventions we had was the medical assistants that work in the clinic have the same access to the medical records, and so then they're able to, we task them with adding that to their standard work. So they're checking in the patient, they check the blood pressure, the pulse, the other vitals, and then they'll go through the preventative health maintenance checklist and to see what is due, because they have access to the chart just like anyone else. But then, so it's only 45 to 50 seconds for colon cancer, but then if you add on, do they need diabetes care, do they need a pap smear or something else like that, that can add up to 3 or 4 minutes. You multiply that by 18 patients a day, all of a sudden you've saved 45 minutes. And I shouldn't say you saved 45 minutes, you've reallocated 45 minutes to go into addressing, getting more frontline feedback. How can I help this patient out? In getting back to that target actual, please explain, they're not at their target for diabetes because their fridge their fridge went dysfunctional and their insulin, which needs to be refrigerated, went bad, so they weren't taking it. So that's something that you can then loop in the social worker on and attempt to address some of those social determinants of health that are outside what I can control as a provider. Does that kind of answer your question?
Yeah, definitely.
One question I had was, you said that during your residency, it was frustrating and inspiring being on the front line. And I thought that was an interesting choice of words. How was it inspiring?
The inspiring in the multidisciplinary effort to help people. It's really, so it's interesting to see at Hennepin, one of the most eye-opening things for me was probably a year into my training, I had a patient who came in with stage 4, I think it was lung cancer, but clearly metastatic, in the hospice window of things, and the patient had family with him. And I went in, I'm like, oh, well, he has family. And it was that was not the norm, but that was the exception. And so a lot of the patients that we see are, for various reasons, they've fallen through the cracks, and whether they either don't have family or their family has been separated or so on and so forth, they're there on their own. So it's bad enough to have stage 4 cancer, but then to be on your own, and a portion of those patients are homeless on top of that. And so I bring that up because it's really an interesting observation that is so outside of what I grew up with. But then to answer your question, so we have a lot of patients then that are in this situation where they don't have help or support, and it's really difficult. So how are you going to give chemotherapy to a patient that's on the streets? Are we're gonna run some chemo in and then watch them for a day, and then they're gonna get fevers and chills every night. We're just gonna send them out on Nicollet, which sometimes happens. But so it's really hard to see that. But then you see all the various different staff members, whether it's environmental services or providers, nurses, so on and so forth, that go the extra mile for these patients that have these big gaps in their social support to help them out. Whether it's a nurse like bringing in a book for a patient, or we've had providers where we've pooled up. I mean, this isn't a social policy fix, but we've pooled up up to $80 to like get somebody a suitcase so they can get their belongings and something when they leave. And then just the dedication of I think the more inspirational part is the dedication of the staff at Hennepin County and at Denver Health, which is the county hospital in Denver, because you don't go there for the money, because you make what we call the league minimum. You go there for the mission, and it's really inspirational to see people that could easily be making decisions to live an easier life where, quite frankly, some of the patients aren't always that nice to us. And if you go to a hospital in the suburbs, you still have that occasionally, but not nearly as often as you would at Hennepin. And for people to not only put up with that, but to decide to work with that because they know that there's extrinsic factors that are driving that behavior, that really is, to me, inspirational.
Hi. So I'm wondering, you were talking about how with certain situations, you have to take a lot of time in the beginning of your meeting to either work on literacy or there's some kind of cultural barrier. how do you handle that if you only have a set amount of time? How do you get around that and help the patient?
So a very good question, and if there was an easy answer, it would have been fixed 10 years ago or probably 20 years ago. So one of the benefits of Hennepin is we claim, I haven't independently verified this, but we have the most robust interpreter services in the country, and I think we do. We have 142 languages, I think, at last check. We have in-house 24/7 Spanish, Hmong, Somalian, Russian, and I think we're now getting in Arabic. And then we have these iPads otherwise that with a language line that we just wheel right up to the patient's bedside, and it's actually revolutionized the interpreter experience with the patient, because historically it was on a phone where you'd either hand the phone back and forth or have two receivers on the phone. But so we've recognized that that's a challenge, and it's a challenge to our efficiency, and it gets back to if we're not efficient, we can't keep the doors open, we can't fulfill our mission. And so this also gets back to who else contributes to the healthcare of the population. And so we obtain support from our financial department to making the case to say if we improve our interpreter services, we should have higher turnover in the clinic. We should be able to see more patients. Not only is it good for access, it's good for revenue. So that is the answer to the interpreter portion. The other portion is much more difficult. If there's other issues that are coming up that aren't, it's not a standard, I have ankle pain, I'm going to put your ankle through the range of motion and then determine whether or not to get an x-ray and then send you home with some ibuprofen. There's a lot of really difficult cases that walk through the door, both in our clinic and our hospital. And that's the part of a job that we say it's not the banker's hours. And so part of it is you just have to be flexible with that, is with respect to timing. Part of it is that, again, we are using quality improvement efforts to try to figure out is there a better way to deal with delays? Because you don't want to shortchange your time with patients, because that is really where that frontline patient contact is. That's what you go into the job for. That's how you provide the best care. But so there's certain clinics, including our cardiology clinic, where we're piloting a more flexible appointment time, and actually those little vibrator things you get at the restaurants with the lights. So to give the patient those. So if you're behind, the patient shows up. That's next after that, the patient that's taking a longer time, they can get one of those little things and walk around the hospital, go out, go for a walk or something, and then be notified 5-10 minutes before, so they're not stuck in the waiting room. So I don't know if that totally answers the question, but some of the stuff can be overcome by systems fixes, but I'm continually surprised by things I never thought I would hear or see that come through the door that you can't prepare or create a system to include. So, yeah.
I'd like to ask an economic question, even though I'm not an economist. But it seems to me that there are so many reports about lack of doctors, or PAs, or nurse assistant, nurse practitioners in, for example, rural areas or in areas that are close by. And on the other hand, you hear about medical schools keeping population in the medical schools down, which at least to me as an outsider says there's something here about the greed that's going on, and that some of these problems could be fixed by socialized medicine or a medicine that would work more with universally with poor other people if there were more practitioners.
So that's a very good question, and it's a hot topic. And so healthcare, or health economics 101, one of the reasons why there's health economics in addition to just economics is that they focus on 4 differences between regular economics and healthcare. But one of the healthcare ones is the barrier to entry in what they call the physician or the provider market. And so there's been hypothesizing that that medical schools and residencies keep their numbers down to maintain the market, to keep demand, to keep salaries high, in order to again, to kind of quote unquote protect your own. I can't speak intelligently on whether how much that is true, if it is, but that's certainly been identified as one of the reasons for the lack of a physician shortage. I think the bigger, so part of that would have to be changed through national policy, because Medicare funds resident spots, and a lot of the your residency is basically, for instance, Hennepin County's, our internal medicine residency, I think, is stuck at 20 because Medicare won't fund anymore. And so that's through the most recent healthcare reform where they set the targets for that. Medical schools, there's more for-profit medical schools opening because the demand for not-for-profit medical schools is so high that they're trying to fulfill that demand. Whether or not that equates to a success for the healthcare of the country, I think, is to be determined. I think, and this is me opining here, but the low-hanging fruit is reevaluating the incentive for different specialties. And if what you're getting at, so we have a healthcare shortage for primary care providers in rural Minnesota. And Minnesota is actually at the forefront of policy, or we were on this, in that the University of Minnesota Duluth Medical School was created by the state, funded by the state, and the mission is the very issue that you bring up, which is we have a rural healthcare physician shortage. So the mission of University of Minnesota Duluth is to accept applicants that are going to that have an interest in primary care outside of the Twin Cities. So that's something that most other states don't have. So Washington, Idaho, Montana have a consortium where they have a similar thing, but I don't know of any others throughout the country. But that is ripe for policy improvement. And part of that goes back to healthcare reimbursement. And I don't know, this population's probably too young to remember healthcare reform of 1994, but the American Medical Association opposed Hillary Clinton's healthcare reform in 1994. They supported the Affordable Care Act in 2008. But the reason I bring that up is that there's a lot of specialties that have a lot of money that drive the political interests of certain medical associations that don't want to give up their market share of reimbursement. And so that's why you'll see the highest board scores trend towards the highest paying specialties. And so we have this, what we call the brain drain into dermatology and interventional radiology, because they pay the highest and they have the easiest schedules, whereas the people that work the hardest and actually probably provide the most benefit towards improving the gap for health inequities is in primary care physicians that serve low socioeconomic status populations. So I don't do policy per se, but that's something that certainly has been, I know Hennepin County advocates for reimbursement mechanisms that would support a market incentive to change towards that. But there's a lot of lobbying that goes on, that part of it makes me less proud of my physician colleagues in a certain sense. So.
Do any of you have questions for Amy or me about being students in this type of situation and what we can do, or being at this level?
So,
Perhaps what kind of made yourself aware? How did you kind of get into this aspect of maybe reading up on healthcare in like a global sense, or even world sense, and national sense, kind of making yourself more aware of policy level, not just kind of how biological mechanisms work and how organic chemistry works, but kind of the larger scope that you start reading, as you go to presentations, and kind of broaden your perspective.
Well, to be honest, some of the policy stuff is right over my head, but I think just exposing yourself to as many experiences as possible is very important, because let's say you go on like the VITA or medical brigades trip, and then you come back and you say, well, that was great, there's health disparities there, now I know about health disparities. And that's not really enough. you get one aspect of it there, but maybe you need to branch out a little more and see how it might look in our own community, and look at maybe at St. Cloud Hospital how that might look. Maybe look even at a closer community how it might look for populations within St. Ben's and St. John's. So just being aware of different ways issues like this can present themselves.
Yeah, Luke, you took the words right out of my mouth, because I was going to say it, go more local. I mean, there's all these trips, and not anything against them. Those are great trips to go on. You get great experience. But, I mean, all my experiences have been within my hometown or nearby, and you get just great experiences from that, too. And you see the disparities that are happening in America as well. And it's not just third world countries. It's here, too. And then you can make an impact in your own community. So,
You guys are making my heart melt with those words. I also sit on the global health committee at Hennepin County and at the University of Minnesota, and that's one of my big pushes. Is if our mission is to really talk about global and underserved medicine, we don't need to send people to all corners of the world. I mean, you can walk out the door of Hennepin County and probably hit 6 different languages by the time you go a block and a half. And if you want to see health disparities, you'd see larger health disparities driving up to the Red Lake Indian Reservation than you would going to Rwanda. And yet we're not sending people up there. So,
as HCMC worked alongside other organizations or community leaders to better target these populations that experience disparities?
So that's a great question. And so we just spent the last 3 days, the executive leadership team, of setting our strategic deployment for 2017, which is basically trying to align the efforts at HCMC to fulfill our mission. And so what I'm in charge of is the quality and safety pillar. And this is the first year in the entire strategic deployment history, to our leadership team knowledge, that health disparities has even come up as a conversation topic. So it didn't make it on our annual plan as in something that we're going to resource to the highest level, but it's going to end up being part of our strategy for fulfilling some of the quality gaps that we have, or closing some of the quality gaps. And as part of that, we actually have a innovations group at Hennepin, and we just on last Friday signed a contract with, it's called NowPow, NOWPOW, and it's a entrepreneurial startup that does exactly what you're saying. So it engages, it provides bridges between the communities that suffer the health disparities and Hennepin County Medical Center, to the point where to a further reach than we currently have now. Because right now we have community paramedics, and we have so community paramedic is someone that goes out and, for instance, will check on a patient that's living out of their car that we discharged 2 days before, and we need to recheck their weight and get some blood. We can send a community paramedic out to the Target parking lot on Lake Street, and so that's something that we currently have. But this NowPow is their whole mission is to extend the reach of hospitals such as ours. So they're currently working at the University of Chicago Hospital, and then we're partnering with Allina, which is Abbott, and a couple other hospitals in the Twin Cities to engage their resources. How that's going to look, I don't know, but over the next year we'll find out. Somebody else have a question? Oh, we got a couple.
So you mentioned people making the changes are not the people maybe out front line. Right? So people might have different letters behind their last names and have different specialties. How does the communication actually work? You mentioned that it's more fluid now than it was in the past between policymakers and frontline packages. Or is there board meetings or continuing education?
So that's a very good question. So even within Hennepin County, so I'll start there. When I started in 2012, I asked my boss and my physician boss, and then my informatics boss, so I used to do computer stuff with the electronic health record in addition to clinical stuff. And so I asked both my my physician boss, my computer boss, how do I get data? And they couldn't answer that. And so for a safety net hospital of 6,000, that employs 6,000 people and has, $880 million in revenue every year, that was pretty surprising to me. But it's not that uncommon throughout the country for the non-Kaisers of the world that are just trying to stay afloat to not have that infrastructure in place. And so over the past 3 years, we've improved that infrastructure significantly to the point where I now meet, in my quality role, I meet with our analytics head, our electronic health record head, and then the clinical chiefs of the other departments. We meet on regular basis to streamline the flow of data. Because to what I was trying to say up there, and maybe it wasn't very eloquent, but that without clinicians understanding where the gaps are and the healthcare organization, it's really hard to target the resources to the area that's going to have the most effect. And so that's something that we've done at Hennepin. We've really improved the cohesiveness of data flow. And then that is actually starting to extend into population health, which I didn't go into here in the interest of time, but we have an accountable care organization where we now, we will pay, or we'll get paid by the state one fixed fee for the entire year for a patient. So they'll give us, I'm just throwing this number out, but like $30,000 to take care of Joe, who's a homeless gentleman with COPD and heart disease. We get that much money to care for him for the year. And if he ends up using more than $30,000, we're on the hook for it. So we have every incentive to keep him healthy, so to keep him out of the hospital. And so we dedicate more resources to, especially the information technology resources, to making sure we're staying on the ball and streamlining his care. As far as the policy part, so once a year we set our policy agenda. The Hennepin County Board sets it, and then we interact with the state and the federal government. And so the big issues that we have now are that some of the Obamacare changes, the increase in insured population has actually decreased some of our compensation for patients that can't pay. And so that's some of the advocacy that we're doing now to try to align those payment structures to be more, what we would consider more fair to us. But that interaction occurs with our board, and we have a public relations person who interacts with the legislature. We have I don't want to call it lobbying, but we have somebody that goes out and interacts. But so to be clear, I don't know if that relationship has changed in the last couple of years, but it's clearly functioning because we interact with the legislature, and we have, Al Franken comes for visits every now and then and stuff. So does that answer the question? And then somebody had a question.
You hit my question when you talked about this.
Do you think federal and state legislation is like an effective way to curb disparities in healthcare?
If done appropriately, yes. And I'd give the example of the fact that our board, and I'm not trying to drag HCMC through the mud, we do a great job, but our board did not discuss quality at all. For quality metrics, are we providing quality care, until the government incentivized it. And I think that it's not just Hennepin that was that way, it's other institutions, but without getting, again, too much into the economics of healthcare, the old reimbursement system where we got paid for every single thing we did to a patient, whether or not it was good, bad, or ugly. So if a patient got sicker in the old system, I got more money because I got to order more tests and take care of the patient extra days, and they'd stay in the hospital. So every time you did something, made a wrong medical decision, make a patient sicker, the hospital would make more money and the clinician would make more money. So that's clearly a perverse incentive for providing health care. So initial healthcare reform helped to curb that, but the long-lasting effects of that, which is that there's still a lot of healthcare waste that goes on because there hasn't been the market drive that, for instance, an engineering company would have to make sure their products come off the line with the highest quality. That market drive hasn't existed in healthcare. And so there needs to be, I think, to answer your question, in my opinion, additional external incentive to focus on these. The tricky part is getting back to the carrots, because so many things fall outside of the healthcare that direct patient care contact. And that's one of the big things that we struggle with at Hennepin, because a lot of healthcare policy at the federal level deals with, so for an example, heart failure readmissions. If we discharge somebody with heart failure from the hospital and they come back in within 30 days, we have to pay for their recurrent hospitalization. We're on the hook for that because that's a policy that the federal government put in place. It's a good policy, but we're disproportionately affected because we have the highest proportion of patients we're discharging to the street. And so they're more likely to not be able to take their medications or not adhere to what we would deem a cardiac diet because they're eating food at the homeless shelter and they don't have a chance to figure out whether it's low salt or to get the best food. And so, so while it doesn't incentivize, federal initiatives do incentivize quality of care, there's clearly room for improvement in how they're disseminated to the front lines to provide kind of the levelest playing field for everyone that's providing the care. Does that kind of answer the question?
Oh, I have a question. So I guess in the season we're in with all the politics going on, I guess a lot of people pretend to know that they understand the healthcare system and have a plan for change that they can implement. If you were a policymaker, how would this quality control look and what policies would you implement?
Ooh, that's a good question.
I'm sorry that it's a loaded question, but
No, it's interesting. So the first part of your question was one of the drivers for me going to get my master's in economics, because I got so sick of people engaging in healthcare reform discussions, and I thought I knew the right answer, and then when I started to read on it a little bit, I'm like, I don't think I know the right answer. And then that kind of spurred some intellectual curiosity to pursue additional training in that. So the most efficient way. So another thing I didn't talk about here, but I think is worth noting, is that healthcare is moving towards value-based reimbursement. So we've gone away from reimbursing strictly on the number of tests you order or the number of days that you're able to hold the patient hostage in the hospital to maximize your financial benefit. It's moved towards value. So if you provide high value care, you will get reimbursed more than if you provided low value care. And high value care is defined by value is equal quality divided by cost. So if you can do anything to either increase quality or decrease cost, you're increasing the value of the care. And so the reason I bring that up is that that's what drives healthcare efficiency. And that's what federal and state policy should best reflect, in my opinion. And hands down, the most efficient way to do that, the lowest hanging fruit in healthcare reform for improving quality, in my opinion, quality and factoring in cost, is to go to single payer. The problem is we don't have the political climate to do that right now. And one of the biggest things that we talked about in my policy training for the economics and policy degree was, not only do you have to have something that makes sense, like economically, but you have to have the political will in order to implement it, in order to even to consider it as something worthy of pursuing. And so if you talk about administrative costs for single payer versus our current multi-payer system, so I think it's roughly 20 to 21 cents per healthcare dollar spend right now goes to administrative costs. And if we went to single payer, that goes to 3 cents per dollar. So there's no other single intervention you can do in the healthcare system even remotely close to getting a 17 cents per dollar savings. But we don't have a political climate to do that right now. And so Colorado's pursuing that, right, for this election cycle. And there's a group in Minnesota that is dedicated to trying to push this along, because the Affordable Care Act does allow for states to trial single payer. But I don't think we'd get there, at least not in this election cycle, based upon what you see on the news. But the other interesting thing that I think is worth looking at is implementing more quality metrics. So this pay for performance. So if our patient population hits, whatever the target is for diabetes control, we get increased reimbursement. But then to have that adjusted for the social determinants of health that currently aren't in the equation. So for instance, what that looks like in real world for Hennepin County is that our target gets lowered a little bit in the short term, because we have patients that are more affected by the 90% of things that affect health outside of clinical care. Does that kind of answer your question? Yes.
Can I make a little statement, ask a question? So when I came up with, I'm Jeff Anderson from Peace Studies, and so when I came up with this kind of topic for the conference to focus on health equities for our Peace Studies conference, I thought of it as kind of like dealing with racial disparities in healthcare, or disparities generally, is like Peace Studies on steroids, all right? Like literally, steroids you're injecting. But, I see these two nice, I wanted to have it have an impact on students here. So I want to loop back a little bit to, because your last slide I thought was great on kind of focus on students as agents of change. And so, we've got a Johnny there, we've got a Benny there, and do we see them down the road as being able to withstand the informal curriculum that they might experience in their professional degrees to maintain an interest in health equity? And I suggest like a vaccination model, okay? In a vaccine, you have one vaccine, you might get some immunological response, but you work on trying to get a stronger one, or sometimes you have to have a booster. And so what Amy said there that made me think of something is that, maybe that for Amy, doing something abroad isn't going to give enough response necessarily to hold her into the health equity, given all the stress, all the informal curriculum. So maybe you design a vaccine, or you all out there try to design an undergraduate experience, and we try to design one for you that's kind of multivalent, so there's lots of things that gives you the ability to be protected from what's going to come, which is family and busyness and an informal curriculum where they're saying, man, you should go down the road, go the road. What are you talking about? That guy, that Hoody guy at HCMC? No way, This is the way to go into dermatology, and, you're gonna like it better. And so I want to highlight one of our, Roy Ketchum, I saw you come in there. Yeah. Can you say a few words about one part of a vaccine that I think we can offer here? Is a new change we're making in Guatemala for 2018?
Yeah, thanks. So I'm Roy Ketchum. I'm a faculty member in Hispanic Studies and Latino Latin American Studies, and I guess sort of a Peace Studies ad hoc supporter. We have an existing program in Guatemala that many of you may be familiar with. It's a semester-long program with the kind of, in terms of a language piece, there's a core one-on-one model where we do 5 hours a day, 5 days a week. And we have at least one student here who's Benedict. Lindsay can tell you more about it. I don't see any others right now. But within that existing semester program, we saw the opportunity to open a new, what we're characterizing as a pre-health track. And students will do the same curriculum as the existing program with two specific health-related pieces. In the second phase of the program, which is a 10-week phase, that one-on-one language piece will be oriented towards medical Spanish, which could consist of some terminology, but also some low-key simulations, some conversations around health-related questions. So it won't be a clinical experience. It will be really, it's embedded within a language school that has a lot of experience working with people in medical professions. The most specific I can say is that they have a program with the University of Virginia where their residents and some even graduates, a range of healthcare professionals, come to the same school that we work with, and they spend anywhere from 2 weeks to 6 or 8 weeks, and a core of their program is working one-on-one language with those teachers that we work with. And then we'll also have a small 2-credit course that is still in development phase, but along the lines of a medical anthropology, looking at some global health questions, with the hope that we would bring some healthcare providers in to do some talks and things like that. But again, some interactions out in the community, but expressly not kind of clinical work, but an engagement with some healthcare issues in Guatemala. So.
All right. So, Amy, if you're wondering, I hope I made a difference on that, being on that panel today. I think I can say you did, because it made me think, because I've been, in conversations about this in some ways, and I used to be on a reentry program for HECUA on a task force, and what we learned, it's basically how do you take that abroad experience and bring it home. And what we learned is that you have to load a lot of it up front, because if you go there and then you fall back into school, so you actually introduce them to the local community here that might bear some similarities to what they'll experience in Guatemala. So then when you go there, you're all set to come home and re-engage. So I think we're going to wind this one down now, okay? Because we were supposed to be starting dinner at 5:30, but for a few minutes here, Dan, would you be willing to visit with folks if they wanted to?
Of course.
All right. If we can thank our student panelists and Dan. Thank you very much.